While Medicare receives the most attention in the mainstream press and during elections, Medicaid has actually grown into the most important issue for the country. After decades of faster-than-inflation growth in spending, Medicaid now comprises 20 to 40% of the budget for states. Unlike the federal government, states cannot print money and must balance budgets. Therefore, Medicaid has become the biggest concern for states. At the federal level, with the passage of the ACA or Obamacare law, and the Supreme Court ruling that states cannot be forced to expand Medicaid as required by the law, up to 26 states are indicating that they will refuse to adopt Obamacare. Expansion of Medicaid was the crucial mechanism by which the law was to expand health care insurance coverage. The American healthcare system spends a stunning $2.8 trillion with a T each year on healthcare through private insurance, Medicare, Medicaid, CHIP, and other services. That is 18% of the entire gross domestic product, according to the White House. 16% of that $2.8 trillion goes to Medicaid for an amount of $460 billion. Medicaid is growing at a rate of 7%. Eligibility requirements for Medicaid vary from state to state. Overall, more than 40% of the Medicaid population are disabled, and only 14% are low-income adults. That number is supposed to increase under Obamacare. Several challenges will have to be overcome if the total population of Americans receiving Medicaid expands. Because of the low payments from Medicaid to healthcare providers, expansion of Medicaid will further strain hospitals and nursing homes. The shortage of primary care doctors will also get worse. Even under the current situation in the 50 states, not all healthy individuals eligible for Medicaid sign up. Therefore, the extra funding provided by the ACA law will be no guarantee that more people will be covered, even if all states agree to opt in. To address all of these challenges to state budgets posed by Medicaid, states are acting on their own. Massachusetts recently passed landmark legislation that will cap Medicaid spending and eliminate fee-for-service. Also, presidential candidate Mitt Romney promises to give states more flexibility with federal matching funds. To understand better how all of this affects the markets, healthcare companies, and what the election will mean, we have assembled a panel of experts. Dr. Ben Summers is a health economist and physician from the Harvard School of Public Health and has published several important papers in the New England Journal of Medicine on Medicaid. He has also worked in the federal government in the Department of Health and Human Services, which oversees Medicaid and Medicare. Dr. Bijan Salahizadeh received his medical degree from Columbia, New York, then went to work for Medtronic, and now runs the venture capital company NaviMed Capital. And Mr. Tom Scully was the former director of the Centers for Medicare and Medicaid Services, overseeing the checkbook for the largest division of the federal government, even bigger than the budget for the Defense Department. Thank you. So here we are with the panel. We're in New York with at the Reuters headquarters in 3 Times Square, and thank you for them helping us with this production. So why don't we start out now with Dr. Summers.
As the intro kind of laid out nicely, Medicaid's a combined federal-state program. The federal government sets certain minimum requirements for coverage, for eligibility, and then states have discretion within those guidelines. And the federal government picks up between 50 to 80% of the tab, depending on the state. Right now, roughly about 2/3 on average of Medicaid spending is from the federal government. Now, the program covers particular groups of low-income Americans. There's a misperception among a fair bit of the general public that Medicaid covers all low-income Americans, which isn't the case. Medicaid covers people with low incomes in particular categories of eligibility. So people with disabilities, children under the age of 18, parents of young children in the home, pregnant women, and elderly adults as well with low incomes. What's conspicuously missing from this is a large group of uninsured adults who are those without a disability and do not have children in the home.
I did not realize that until preparing for this show that. Go ahead. Yep.
And if you look at the breakdown of coverage in Medicaid and then you compare it to the expenditures, there's an interesting dichotomy. The majority of coverage in terms of number of people is primarily for children and for low-income adults. If you look at the spending, and this is where that slide kind of mix those two issues together, spending is driven by adults with disabilities and the elderly, and they are disproportionately costly to cover. And that's an important number, up to 138% of the federal poverty level, and that's roughly $15,000 a year for a single person, $32,000 a year for a family of 4. And in addition to lifting that threshold level significantly higher than it is currently in many states, the other big change is this traditional issue of the category of eligibility is no longer the driving factor. You don't have to have a disability. You don't have to be a child or a parent with a child in the home. Any adult that is under that income cutoff will be eligible. So in a sense, it actually creates the Medicaid program that a lot of the general public thinks we already have, essentially a safety net insurance program for the low income. So there's significant questions about how this will play out. The Supreme Court's ruling in June gave states discretion as to whether they do this expansion. That has obviously made predicting the total enrollment and the total costs much more uncertain. But ballpark, we've seen estimates ranging from 10 to 25 million adults, new individuals coming to Medicaid on a baseline of about 60 million. And costs also vary widely in the estimates, but the Congressional Budget Office by 2019 estimates, as originally passed, about $100 billion a year, and that was when every state was going to be required to do it. And the baseline Medicaid costs for 2019 were about $400 billion. So kind of fitting in that framework I said earlier, the people coming in are not as costly as the disabled and elderly that really drive the majority of Medicaid spending. So 16 million more people and $100 billion by 2019 per year, which is about 20% more than the baseline federal spending. But major questions that are still unanswered, and look forward to our conversation here today to talk about some of those challenges.
Any comments on that? Go ahead.
No, I think all the numbers are right. A couple billion here, a billion there. Medicaid, who knows the difference, right? So I don't know. Do you want to jump in on the other? Some comments on the?
Well, so that's an important point, is I did not realize that most, I emphasize the word healthy because currently Medicaid requires you to have a disability or some other category. So if you're unemployed or have a very low income, you still are not eligible for Medicaid before
Depends on the state.
It depends on the state.
And
then that's going to change.
Right. And right now, about 2/3 of states don't cover so-called childless adults at all, so regardless of income. And other states have worked with CMS to propose expansions to those groups.
And what if this
complaint you get about the expansion of Medicaid, you can guess he's an advocate of expanding, and I would be too once we get our act together.
Right.
So the problem you have is, you're collecting $2.4 trillion a year revenue, and you're spending $3.6 trillion a year revenue. So if you could find a way to not have a 9 or 10% of GDP budget deficit, a lot of people would be for expanding coverage, including me. But you shouldn't be doing it. You should do the biggest expansion of entitlement programs in the history of mankind when you have when you're collecting already 66% of what you're spending. So I think the fundamental problem you have with that Romney and a lot of Republicans have with this is paying for the damn thing and making sure it's financed. And I think that's the fundamental problem. And the other issue, which I think we get into, is Medicaid is structurally a disgrace as a management thing. I'm a big fan of Medicaid. I'm concerned as anybody is about the.
Just emphasize to the viewers, you used to oversee
Medicare and Medicaid. And at the federal level, if I were governor, I'd do the same thing. But for example, you said that Medicaid is a $450 billion a year program, roughly. If you look in the federal budget, you'll see that roughly, just to round numbers, $300 billion of it is supposed to be federal, and roughly $150 billion of it's come from the states. $50 billion of that, roughly, from the states is air, because every state cheats like crazy. It's just a fact of life. They have. Anybody out there knows you have nursing home taxes and hospital taxes. So 47 states have what are called provider taxes. They tax the hospitals on Monday, and they put it up for a federal match, and they pay them back on Tuesday. And they do that in 47 states. They have things called intergovernmental transfers. This has been going on for 30 years. But the Medicaid program, unfortunately, has become a game of cost shifting between the federal and state governments. So one of the major arguments for block granting it, which I'm not a fan of, but one of the major arguments for what Tom Daschle talked about a couple weeks ago, which is turning it into a per capita allocation that's a little more flexible to a recession.
Is this what Mitt Romney proposes if he's elected?
Mitt Romney proposed a block granting, which is a simple, more simplistic term. And the argument from the Democratic side, which has some legitimacy, is if you give a block grant and you give, let's say Pennsylvania has, I should look at the numbers, but if you have to tell a state, we're going to give you a block grant, which you have today, and adjust it for inflation, going forward, well, if the level of the uninsured goes up or there's a recession or something, that doesn't adjust for that. The program is basically a third disabled, a third long-term care, which is nursing homes, and a third women and children's health care, in rough terms. And so most advocates would say of this proposal, when Tom Daschle, a friend of mine, was one of those a few weeks ago, would say, look, let's take a per capita amount for each of those people and adjust it for medical inflation, not CPI. So if more people are in nursing homes or more people come down, it's more flexible. But the problem with the program structurally is that there's a competition among the states. And if I were a governor, I'd do the same thing to find a way to cost shift to the federal government. So they spend a lot of their energy and time, instead of managing the program, trying to find a way to get the federal government to pick up the tab. So, for example, if you look at Mitt Romney's, or the Massachusetts miracle of covering all the uninsured, guess how much money Massachusetts put into that? Zero, not a penny. It was all funded by the other 49 states through a Medicaid scam.
Well, we're going to have a separate talk.
The Medicaid program has basically gotten out of control because of that.
Massachusetts just did something really big recently to address those rising costs, and we'll get to that in a minute. Where they eliminated fee-for-service and capped Medicaid spending based on a 3% growth of CPI.
But it's the second biggest program in the government, and it's, if you took it to a government class at Harvard and actually explained how it's run, they'd throw up.
Yeah. You have any comments?
Yeah, I think the thing I'd say about Medicaid from my perspective hearing all this is that it's exceedingly complex compared to the Medicare program. And you ran it, and you do a lot of research in it, and I sort of invest in companies that may be affected by it. And it's not something you can easily explain. There are 50 states that make their own individual decisions about it. And so within that minutia and that detail and complexity, it's the least understandable and probably therefore the one that's most ripe for cost shifting that people don't understand and lack of transparency. And so I think if Obamacare helps solve some of that, that's great. But from my perspective, market-based solutions like Medicaid managed care, while they're not the salve that solves everything, they certainly have been shown over and over again to reduce costs. Maybe 20% or more. And I think, I'm a believer in the free market. We all are. And I think managed care has consistently been shown to cut Medicaid costs. And the more that's embraced as a solution, I think it's certainly half of Medicaid is under some kind of managed care arrangement now. It's hard to see a future without that becoming an increasing burden.
All the governors, that was interesting on the federal level. There's lots of fights between Democrats and Republicans about Medicare becoming more managed care. About 26% of Medicare is managed care, and that's a huge philosophical fight. At the state level of Medicaid, all the governors are doing this. There's no disagreement between Democrats and Republicans because it works better, it saves money. And, I think that's the way every state's going, and it's the appropriate thing to do.